Not much ado, we shall be continuing with our class. R.A.T.S we know, and the expansion also we know. And this is my book, The Tips. So, hypersensitivity reaction type 2. This will be the topic for the day. Look at the history over here. Let me see if you people are able to make a diagnosis. A 50-year-old male came to the doctor with progressive weakness of the extremities. On seeing the television or reading for some time, he noticed a diplopia which worsened as the day progressed. There are very many keywords over here. Progressive weakness, diplopia, worsened as the day progressed. What is your diagnosis? I hope you people have got a clue of it and explain the pathogenesis of this disease. So, this is over here. There is a drooping of the eyelid and there is a compensatory attempt to lift the other eyelid. In fact, both are equally weak. So, the diagnosis is good. It is Myasthenia Gravis. But the class is about type 2 hypersensitivity. Let us see how complete our class can be. Here, the antibodies react with the antigens in the cell surface or in the extracellular matrix. Every word of my class is important. No one words, please. The antigens may be intrinsic to the cell membrane or matrix. The exogenous antigen gets absorbed on the cell surface or the tissue matrix. So, either the antigen may be present in the cell or the tissue itself, or sometimes it can be exogenous. They get stuck to the cell or to the matrix. And there are two types of antibodies, IgG and IgM antibody. Now, what is the pathogenesis of this type 2 hypersensitivity? There are two important steps. One is called opsonization. Opsonization means it is a coating of an antigen. It can be a bacteria or any substance with a particular protein so that it is made conditioned for phagocytosis. It is ready for getting phagocytosed. It is recognized as foreign. The target cells can be coated with IgG or IgM. They are the antibodies. After which you find that there are different routes of destruction, which I shall be explaining. It can be either Fc receptor mediator or complement mediator, or it can be an antibody dependent cell mediated cytotoxicity. Three things are there: Fc receptor mediation, complement mediation, antibody dependent cell mediated cytotoxicity. These are three different mechanisms and all the three will not occur in the same patient or condition. Dear students, please by heart this particular table. What I am going to do is, I am going to read this table for you people. As I mentioned earlier, the type 2 reaction can be complement mediated or it can be antibody dependent. In the complement mediation itself, you find that there are three particular examples: opsonization and phagocytosis. This can happen in a case of autoimmune hemolytic anemia and ITP, idiopathic thrombocytopenic purpura. Another example is transfusion of incompatible blood. Supposing you give the wrong group of blood, you find that there can be a reaction. The third one is it can be induced by C3A or C5A, complement dependent. And the classical example is Goodpasture syndrome. Don't worry about all this. I shall be giving you enough pictures and explanation. In the case of antibody dependent ones, you find that the antibody mediation is causing a cellular dysfunction. It can be Myasthenia Gravis or a Graves' disease. So this particular table is elaborate and highly informative. So you people can by heart and write it. See this one. As I mentioned earlier, complement mediation or FC, it is a receptor mediation. And the best example can be glomerulonephritis. Glomerulonephritis is an immunological disease. This particular picture I am showing you just to recall the structure of the glomerulus. So you find that there is an epithelium. The blue color is the basement membrane. This is the endothelium. This is one capillary of the glomerulus. There will be multiple capillaries. So this is the supporting mesangium. In this, what happens? There is an inflammation which is called as glomerulonephritis. This will be dealt with in detail in your systemic pathology. On the other hand, this is a slide of lung. I cannot say it is lung at all because it is solid. Here I am able to see some air space. Otherwise, it is completely filled with blood and there is a widening of the intercapillary septa or interstitium. There is also some macrophages which are coming over here. This is a classical example of a Goodpasture's syndrome. The other example is rheumatic fever. So these three we shall be remembering. And what is the Goodpasture's syndrome? I told you I'll explain. It is a wonderful mnemonic I had picked up from the net. One is glomerulus. This is the tuft of alveoli that I'm seeing in the lung. So there is an anti-glomerular basement membrane antibody. Here there is an anti-alveolar basement membrane antibody. The patient presents with glomerulonephritis. Here there is inflammation. The patient presents with cough, hemoptysis, and dyspnea. The diagnosis can be made by means of a renal biopsy. Here a lung biopsy may be needed. The treatment is supportive by any of the methods. Prednisolone can be a corticosteroid. This can be used for both, or cyclophosphamide plasmapheresis. These are some of the methods of treatment. I would like you people to kindly memorize this one, a very easy table for you to remember. This particular diagram will appear a little complex, but it is worth it. ITP is an essay question for you in hematology. So let us see what is happening. This large cell is a megakaryocyte. From the megakaryocyte, fragmentation will produce the platelets. So this is the platelet being produced and this is the platelet. And because of that, you find there will be some things getting attached to the surface of the platelets, which will be activating the spleen or the other lymphoid tissues. So these are lymphoid tissue means earlier also we had seen B lymphocyte, T lymphocyte, plasma cells, all will lead to antibody synthesis. So there will be antibodies. And also there is an activation of the cytotoxic T cells. So once there is an activation, there will be lysis and destruction of the platelets. That is why the patient will be having a very low platelet count in ITP because of platelet lysis. And in some conditions, even the megakaryocyte can be undergoing lysis. There will be more production of the platelets, but they will be destroyed. Ultimately, you find that these will get phagocytosed by the reticuloendothelial cells. This is what is happening. So the ITP, I think you people will be able to reproduce. There is some antigen which is leading to the production of antibody, which activates the cytotoxic T cells, and then there is a lysis of the platelets or the megakaryocytes, a decrease in the platelets for the patient, which is called thrombocytopenia. The other examples are any transfusion reactions, RH incompatibility, autoimmune hemolytic anemia, ITP, and agranulocytosis. So please remember this one. I think you have got a complete battery of answers for this. Not the least, myasthenia gravis is also a question for you people. Look at this one. This is the nerve ending over here, and this is the muscle at the joint space. So you find that there will be some acetylcholine that is being released by the nerves. These get attached to the acetylcholine receptors and there is a contraction of the muscles. That is how the muscle spasm is maintained. But in some cases, you find that there can be antibodies against the acetylcholine or antibodies against the receptors. So I used to call them blocking antibodies or binding antibodies. Anyone can be present. And what will happen is there will be a destruction of the acetylcholine itself or the receptors, as a result of which the nerve conduction is not transmitted to the muscle. Therefore, there is a flaccidity and a weakness of the muscles. This is typically the pathogenesis of myasthenia gravis. The other conditions with this are Graves' disease, pernicious anemia. Go to my class on pernicious anemia. I would have explained the different types of antibodies. This by itself is a university essay question. Diabetes is a university question. Again, I would have explained. Pemphigus vulgaris. Please make a list of this, memorize it. It is worth its weight in gold. And these are the clinical signs, 5 Ds. Diplopia, dysarthria, dysphagia, dyspnea, and descending weakness. So it is an early sign. I would like you students to kindly be patient. This is the third university question that I'm going to explain to you people. Question which we usually omit in the exam, that is erythroblastosis fetalis. Now what is it? Please follow what I am saying. This is a fetus which is Rh positive. The mother is Rh negative. So this fetus will be having Rh positive cells. But luckily this is the first child. So what will happen is there is a barrier called here the placenta, and these antigens will not go into the maternal circulation. The delivery will be conducted. But during delivery, there will be a tear, there will be a bleeding, there will be a leakage across the placenta. So a few of the fetal cells will be entering the maternal circulation. But then by the time the child is safely delivered, therefore nothing happens to the first fetus. But subsequently what is happening is, I find that the maternal circulation, it has got the antibodies. Rh negative cells have entered and it has already produced the antibodies. You people can imagine what I am going to come to. And as I mentioned earlier, this book, it gives a fairly reasonable amount of general pathology. This is what is happening. In the maternal circulation, there are antibodies, and during the subsequent delivery, you find that the mother's blood will have to come to the fetus, otherwise there is a nutrition. Along with that, the antibodies also will be coming. They will be destroying the RBCs. There is agglutination and death of cells. So there is a severe anemia. At the same time, I find that the fetus is also jaundiced. There can be a severe jaundice. The child can even be stillborn. Kernicterus is one. Hemolytic anemia, another complication. Third one is severe jaundice. So these are the features of erythroblastosis fetalis. Please do write it, and you can diagnose it by doing a Coombs test. See you soon.